who someone is. And that is what led us to create Remina. To begin this special morning, I would now like to invite our CEO Sunita Chowdhury to deliver the welcome address.
Good morning, everyone. On behalf of the entire Remina team, it's my absolute honor to welcome you all today for this special event. To the distinguished dementia specialists, neuropsychologists, healthcare leaders, memory care professionals, caregivers, community organizations and technology leaders joining us from across healthcare and AI and media, thank you for being here. We are especially grateful for the presence and encouragement of organizations like the Dementia India Alliance, the Dementia-care Foundation, Dignity Foundation, DemCare, Jerrycare, and experts from institutions including Apollo Hospitals and Kamakshi Hospitals, along with leaders from the AI and consulting ecosystem including BCG. Today is not just the launch of the product, it is the beginning of the larger mission. A mission to ask a very human question: can technology become more compassionate? At Remina, we believe the answer is yes. In a world where AI is often associated with productivity, automation, and efficiency, we chose to build AI for memory, dignity, connection, and care. Because dementia does not affect only memory, it affects identity, families, relationships, daily life. And behind every diagnosis, there is a human story that deserves empathy. Remina was created to support caregivers, memory care communities, and families through personalized engagement, meaningful routines, and what we call compassionate AI experiences. And I want to take a moment to acknowledge the founder behind this vision, Mr. Srikumar Bhaskara. While many people are building AI to replace tasks, Srikar challenged us to build the AI that strengthens human connection. His vision for Remina was simple and powerful. Technology should not only make us smarter, it should make us more compassionate. The belief became the foundation of Remina. Over the last several months, our team has worked very closely with doctors, dementia communities, caregivers, and AI experts to shape up something that is deeply personal, deeply respectful, and deeply meaningful. And honestly,
Supported in bringing Remina to life. Your trust and commitment mean a great deal to us. I'd now like to take a moment to honor our distinguished guests. I kindly request you to please come forward to receive a small token of our heartfelt gratitude for your presence and support today as I call out the names. Firstly, Dr. Sridhar Vaidishwaran, Assistant Director and Consultant Psychiatrist Dementia-care, DemCares. Trained in Scotland and served as a consultant in the NHS before returning to Chennai in 2015 to found DemCares, the dedicated dementia care initiative at SCARF. His research spans cognitive stimulation therapy, psychosocial interventions, and rural communities. He is one of the most influential voices in dementia care in South Asia. Dr. Subhashini Sarvanan, geriatric psychiatrist and dementia care consultant. Dr. Subhashini Sarvanan holds master's degree in psychiatry and postgraduate diploma in geriatric medicine and has dedicated years to studying and understanding the complexities of dementia. She is a passionate advocate for change in gerontology and respect voice in geriatric psychiatry in Chennai. Dr. Anusha Kumaredu. Dr. Anusha is a consultant psychiatrist with DemCare's team at SCARF Chennai. She is actively involved in research and identifying barriers older adults face in accessing mental health care services. Her work bridges clinical care and community outreach to reach those most underserved.
Ma'am.
Dr. Sujaya Raghavendra combines strong diagnostic expertise with a compassionate patient-first approach. Mrs. Gayatri Ananthakrishnan founder, Dementia Care Foundation Center, Throipakkam Health. She's also the founder of PMH Clinic, bringing her expertise directly to individuals and families who need it most. Dr. Vigneshwar Ravishankar, consultant neurosurgeon, Institute of Neuroscience, Apollo Hospitals. He's a consultant neurosurgeon at Apollo Hospitals, Chennai, with over 10 years of specialized experience. He holds a MCH in neurosurgery from Madras Medical College, MRCS England, and a fellowship in vascular and endovascular neurosurgery from Fujita Health University, Japan. His expertise in brain and neurovascular conditions make him valuable. She specializes in chronic kidney diseases, dialysis, renal transplantation, and hypertension, bringing clinical precision and compassionate care to every patient she treats. Mr. Santosh Ganesh. Mr. Santosh Ganesh is a technology leader and former principal consultant in Boston Consulting Group, where he builds deep expertise in AI, IoT, and Industry 4.0. He specializes in design, architecture, development, and implementation of IoT systems and advanced analytics, with particular passion in applying generative AI to the real-world operations. Mrs. Ms. Abhinaya, Manager, Dignity Foundation. Ms. Abhinaya serves as a manager at Dignity Foundation, a non-profit organization founded in 1995. She wasn't able to join us here today. Ms. Krishnaveni, Deputy Manager, Dignity Foundation. Ms. Krishnaveni serves as Deputy Manager at Dignity Foundation, contributing to the organization's mission of elder care with dignity. She works at the ground level to ensure that Dignity Foundation's dementia daycare facilities, social centers, and outreach programs create lasting impact for senior citizens, especially those from underprivileged. What if care could begin with a person's story and not just their symptoms? Today, much of dementia care is structured around clinical protocols, which are essential to the person behind the condition. Who they were, what they loved, what made them feel safe, seen, and understood. Remina is built to bridge that gap. It enables caregivers and care centers to capture a person's life story, their preferences, memories, routines, and identity, and translate that into personalized, meaningful care experiences. Because even when memory fades, familiarity can comfort, stories can connect, and identity can still be honored. Our vision is simple: to make dementia care more empathetic, consistent, and deeply personal across every interaction. To take us deeper into this vision and journey behind Remina, I would now like to invite our founder and chairman, Mr. Shrikar Bhaskara, to share more.
Since if you want, I can take them. And also, no blood tests, I am perfectly okay, right? Having said that, having my daughter doing her third year MBBS, even at home, I am now in the same, fearful medical supervision. Right? So, with all the intellectual crowd here, and the intellectual crowd, and realizing a lot of clinicians have taken the majority in this room. You are all looking like the TVK of Tamil Nadu. Thank you so much for that. It's truly an honor to have all of you, and your presence for this launch is meaningful, credible, and very special for all of us. Right? So let me get into in front of the intellectual crowd. I feel too small to explain all of this, but still I need to put that in the PPT. So 10 million plus people are living with dementia, 7.5% are senior citizens, and it's going to double in the next decade. And by 2025, our dementia count will be equal to the population of Australia. Right? So 99% of family provide care with no formal support. That is as on situation in India. Right? So a small story, right? So as an organization, we're all technologists. We don't know anything clinically, but we have worked a lot in the US for a lot of healthcare companies. We worked in memory care centers. We worked in assisted living centers and senior living centers, primarily to build a lot of transactional applications, right? So billing software, scheduling software, and the caregivers who are going to the home and then managing their schedule and so on. But we have never built any clinical or medical records kind of a software. So I think 2 years or 2.5 years ago, I got an opportunity to go and spend some time with the residents in a memory care center in Ohio. So I met the person. Her name is not changed, but I was an English teacher for 34 years. And she changed the lives of 350 students every year. And dementia hit her, and she got admitted into one of the memory care centers, right? And unfortunately, that particular memory care center had very generic routines to be run to take care of all dementia patients in all categories in the same way, right? So generally, what has been asked was, can you find out an apple from this particular chart? So the kind of feel that she got was, it was not only a memory problem, but also it's a dignity problem. I change the lives of 350 people every year. End of the day, I'm being asked to identify apple from a chart, right? So and I had an opportunity to talk to the caregiver. His name was Marcus. Extremely hardworking, like all of you caregivers here. But the problem is, he doesn't know too much about Dorothy, right? So they don't know who they were before they go for the treatment. That is the problem with caregivers, and typically it's called CNA in the US, right? So the certified nursing assistant. And I had an opportunity to talk to some of the family members, especially Dorothy's daughter, Sarah. She had the problem of calling the memory care centers every Sunday and getting some updates, right? So it is mostly about did she take her medicine, is she behaving okay, kind of an update, but not really any moments of happiness that you have, or moments of photos that she's able to identify and so on and so forth, right? So every role in this particular memory care center had different problems. Go to the next slide. Now we are trying to create a new category. We worked a lot in AI and Gen AI related solutions, but in this category, instrumental AI we see everywhere, like scheduling, billing, cost reduction, occupancy, so on. But we try to do something in compassionate AI, right? So where we try to scale the dignity, resident identity, personalized care, knowledge transfer, typically what a CNA has to do during shift transfers. And one of the critical aspects, NPI, I would like to discuss with a lot of doctors here post this, and also residents, treating them as a whole people. And this is our mission. Very quickly I'll close it. Why we exist, how we do what we do, and then what we do, right? So why do we exist as a company, and when do we cease existing? We want to make sure every dementia patient deserves to be known. We create a live book like Remina. Can you come forward, Remina? We want to make sure every patient in your community will have their own live book. So we want to make sure the photos are taken, the important life events are digitized, and all the routines are created based on your digital live book, what we are going to create, right? And then what we do, we are calling ourselves the world's first SaaS platform in healthcare industry, which is serving all all stakeholders. We'll see that in a moment. Go to the next one. Yeah. And a story behind our logo. What you see on the left hand side is a logo that has been designed by one of the dementia patients who is using our application in the US, and we wanted to make sure we don't change the gave it to your designer. We just wanted to retain it as it is. You can move on. And go to the next one. Yeah. So there are two critical modules. One is for care communities and one is for caregivers. Care communities, we have deep workflow embedded into our software for every role, and especially for caregivers, we have a training programs, right? It can generate scenarios of dementia patients of different categories, and you can train your caregivers and based on any scenario. And also one more aspect, what I keep hearing from dementia communities is the caregivers go through a lot of stress. So how do you measure the stress of any caregiver and give a report? This is the life book, life story, emotional anchors, NPI cascade, you can capture shift intelligence. There is a family portal who can upload the photos and the life book and life details, and then activity profile. Next one. Role 1, CNA or the care partner, the certified nursing assistant who are going to help the person, right? So what is before Remina and what is after Remina? I will just summarize this. 28% PRN calls has been reduced, 100% shift handover. I don't have to worry about how much she was agitated in my earlier shift. And then 92% drop, 92% success rate in NPI, and then 15% turnover in terms of caregivers. Role 2 is memory care nurse, 23 minutes saved per PRN, NPI trial is 100%, 0 citations, and then 3 tabs, you can get the full PRN documented. Role 3 is director of nursing, again 12.4% antipsychotic rate. The US national percentage is 14%, I am not sure about Indian antipsychotic percent. 97% inspection ready, because our application is logging all the data as you use it. You don't have to go fill the physical forms and then keep it ready for inspection. 0 survey citations, and then 100% citation risk reduced. These are all results that we have achieved in 90 days of time, right? The life enrichment director, the one who plans for the activities and routines, which is the toughest job, because you need to know what their personal life is, and you need to define it on your own. So here 100% documentation. The engagement improvement we have seen, because everything is related to their personal life story. So we have seen 4.8 out of 5. Live book, complete creation, and 2x ASI. Live book is not something what you create on your own. We also try to augment it with a lot of AI, with AI and Gen AI. And then community relations director, the ones who bring residents to your your sales people. 58% tour conversion, and then 2x family referrals, 9 days to inquiry to sign. So we reduced it from 14 days to 9 days, and then 234K revenue uplift. Again, these were the design partners we had in the US. Executive directors and CEOs, your annual revenue increases, your occupancy rate increases, your citations completely reduces, and your caregivers turnover drops down. And this is for family. You get family gets daily updates through WhatsApp, and then 4.57 satisfaction, and 2x referrals, and 100% satisfaction using the family portal. And caregiver training, this is the other module. Again, we will categorize them mid-stage, mild stage, and moderate. Totally, we have close to 50 scenarios. Those are available in the experience centers. After the launch, you can go and check it how it is working. And then and our first design partner in India, TDCF. Thank you, Gayatri ma'am and Purnima ma'am, for trusting in this platform and onboarding us. We are helping them across 3 care communities in Chennai. Signed an MOU. Remina platform deployment is in progress. We are talking to their psychotherapists, and then giving them kind of a handoff. And India's first live book context. We have done that for US. But live book is not very simple technically. I will talk later. It is about building the Indian context into live book, right? Go to the next one. And our community impact partner, DIA. Thank you so much again, DIA, for taking us as a technology partner. And a lot of inputs are their mission and our mission is getting aligned in terms of DemCon, DemLearn, and DemClinic, and so on. Next one. So 90 days real results from 3 to 4 communities in the US. Antipsychotic reduction by 24. Annual revenue so much, 28% PRN calls reduction. Caregiver turnover 15%. Engagement score is 4.8, and 0 citations. In addition to that, we have added it very recently, because a lot of elderly cares, as we talked to them, they wanted these features as well. We use privacy conscious computer vision to identify the simple use cases: resident fall detection, facility elopement or exit detection, repeated wandering, nighttime wandering, unusual time spent in bathroom alerts, bed exit for high risk resident, long inactivity, no movement alert, slippery posture, and then unstable walking pattern. These are all the different events. What will continuously we will go through your CCTV cameras, and then we will try to alert the facility admin. So this is what our request is: a free 30-day design partner pilot, full platform for all 7 access roles, all residents onboarded with live books, NPI cascade and shift handover, dedicated onboarding support, and 30-day results page. Right? So you can't deliver dignity if you don't know who this person, and that's what exactly Remina is delivering. Last one. Okay, thank you all. This is what we want to.
Kind enough to say a few words.
Good morning, everyone. Thank you for having me here, and all of us, I'm sure, are excited to learn about this program and how this will work and the use of tech to look after our elders with lived experience of dementia. Now, I think you have explained what dementia is, and I don't think we need to talk about that. But there is an explosion of numbers. I think we are going to see a huge number, and I don't think we can continue to do what we are doing to support what is coming to us. I think there are different ways to approach looking after elders with a lived experience of dementia in our country, and the first and foremost has to be person-centered care. I think we need to develop more people who are trained to look after people with dementia. I think that's the first step. And person-centered care has to be embedded at every level. So we need more people to look after people with dementia. The second is we need the people trained to look after those who need help and support. And the third thing is to embed whatever we can to facilitate this whole process. I think tech plays a huge role in this, and I think we'll be very short-sighted not to use tech, and I don't think we should be afraid of using AI or any other means of. So it's a huge role in improving care in long-term care facilities, but also people living in their own homes and being supported by professional caregivers. I think that is a huge demand. And I think there are lots of stories which you will all be familiar with about how care at home doesn't actually support older adults with lived experience of dementia. I think training those people and using this means to support them will be an important step to improve the care overall. So I support this initiative, and I will do my best to help in whatever way we can to make sure that this works in our setup. And I look forward to hearing more about this in the near future. Thank you. Thank you.
Everyone. So we had a deal with Remina on the day we signed the agreement, and they said they were having the event today. And after signing the agreement, the other deal was that I would not be speaking at the inauguration. and that Poonima would be speaking. And then here is Shalini calling me on stage. So it's a totally unprepared speech. But having said that, working with Shalini and Mr. Shekhar, and we are a totally non-AI people here working with elders, and to work with people who have been working only with AI. And it was very interesting to have conversations with them. And what was very, I think that made us also sign an agreement with them, and we decided to work with them on the pilot, was the compassion and the understanding that they had about elders with dementia. And I think it also helped that they had also been caregivers, and I think that makes a huge difference when you work with elders with dementia and their product, and we've seen their product, and most importantly, the total commitment that they had. So it's not about selling the product, it is about selling a purpose. I think the company and both the founders and the team had a vision behind the product, and I think that makes a huge difference. And I think the whole of Tamil Nadu today is with mixed fears and hopes with TVK swearing in, and I think you also timed it, at 10 a.m. to launch the product. So wishing you all the very best, and I'm sure we will do extremely well, and we're happy to be the first organization that has also signed up, and wishing you many more. Thank you, but I shall remember this.
Everyone, my name is Purnima. I'm the clinical lead with the Dementia-care Foundation, and I'm always happy to talk a little bit about what we do after our founder and my sister, Gayatri and Krishnan as well. To tell you a little bit about our journey and why it's very significant for us that we have the support of Remina. As many of you may already know, we started this organization in 2019. But we've been talking about it about 2 years before that, because us as caregivers and members of the clinical community felt that while we were looking out for solutions for care for elders with dementia, either because we've had people who reached out to us for help, as well as when we have gone out seeking for help as well, we found that outside of medical support, there was a significant gap in how to keep the elder engaged. Most of the elders we had met and interacted with were ones who have had very successful careers, who have created great impact in both their family life as well as within the community. And to see them, for a lack of a better word, wasting in the house was a very heartbreaking experience for us. So put together, what we did is we spent a lot of time trying to figure out how we can create a sustainable psychosocial model of care for elders with dementia and of course their family members as well. What has significantly changed the last 10 years or so is that we currently are in a space where both members of the family, if it's a nuclear family of 4, children go to school or colleges, the parents, unlike the generation before us, both parents are working. And at the same time, we have a need to care for an elder who is undergoing some level of memory decline. It becomes more crucial to help form a community or a sustainable model where the elder can be better taken care of, so that their quality of life is retained. There is a lot of care provided to the primary caregivers as well, and in an Indian context, being the family members as well. So we started that journey in 2019. To some extent, we were successful at filling the gaps of being able to provide access to care. We currently have about 3 different centers that we had. We started with 1. We were able to fill up a reasonable amount of gap in terms of accessibility by offering to pick the elder up from their home, bring them over. We were able to offer some amount of locomotive gaps where we had disability assisted infrastructure that we were able to build. But a steady increased need was always present, where there was language gaps, where we had elders who were in different states, but were primarily Tamil speaking or Hindi speaking or English speaking, but they couldn't reach out to their local dementia community center for the language gap. We couldn't fill up the gap where an elder was not able to access our center or any of our support centers as well, either because the family was not ready to send them over, or there was a lot of other logistical difficulties as well. They were also bedridden to some extent. So we were constantly in a pursuit of trying to figure out how we can bring a solution for that. And that is at the right time when we met Srikar and his team, where they introduced the online support using technology and now AI as well. And how we can continue to provide that support, not necessarily online but also off. So not necessarily offline but also online. So while we got
So day before yesterday we met. Yeah, so they just invited me, please ma'am come for the launch, and actually my heart is beating pada so totally unprepared. Sridhar knows how much of how much anxious I'll become when there's public speaking. So let me talk about what I do in the place where I am. Okay, so ours is Care hospitals. We have 2 hospitals, we have a clinic, and we have 7 assisted living facilities, and we have home care as well. So what I have noticed is most of our clients, they go undiagnosed when they have a cognitive decline. So if we see 100 clients, 75% of them have got cognitive decline, right? At least a 2/3. So when I first joined Jerrycare and I visited the assisted living facilities, 2 out of 3 clients were admitted already had cognitive decline that was not diagnosed. So slowly we have been diagnosing each one of them, and each one of them required different type of care, right? And very difficult to train all our nurses and our ANMs when it comes to dementia care. So I am looking forward to this application so that I can train all of my nurses, the social workers, as well as the caregivers who are relatives of persons with dementia with their help. And thank you, Remina, for inviting me.
Very good morning. Thank you so much for having me here. I work with SCARF, with dementia-care, and I'm also a visiting consultant at Curie Hospitals. And I work with a lot of elderly in the rural population. So this is actually very exciting, and I did not know what to expect when I was invited. But the presentation and the way it was given to us, it is really exciting. I'm really looking forward to what we can use this application, how we can use it to bridge the gaps that are existing. And working with an inpatient facility, all the challenges that they said were absolutely real, and we face it at a day-to-day level. So when the shifts change and when caregivers expect updates every day because they are not available with the patients admitted to our facilities, because usually for physical health issues, the caregivers are usually staying with the patients at the wards. But for dementia care, caregiver burden itself is a reason, and for caregiver respite, people are getting admitted to dementia care facilities. So giving an update becomes laborsome, and it is currently, I do it through telephone, and I'm very sure that all of our team members do it through telephone, and we keep updating as and when we get the time. But I'm very sure that this is going to bridge that gap. And like they said, a person who's been a professor or a teacher or someone who's been very successful in life, being asked to put blocks, and being asked to put rings on them, arrange the hoops in ascending order. It can be demeaning for those who still understand. They're still in the transition phase to a moderate to severe, but still do understand that why am I being treated like this? I don't have anything wrong. I'm not supposed to be here. So I'm really hoping to, hoping this app will bridge that gap, will help us train our professional caregivers as well as family caregivers, as well as help in supporting our family caregivers and reduce the caregiver burden. Again, this is just the beginning. So
I'm Dr. Sujaya Raghavendra. I am working in Dr. Kamakshi Memorial Hospital, Sirusari. I'm associated with Curie Hospitals also. So regarding one thing which I was noticing about Remina, the diagram which I think Sir had mentioned that one of the patients had drawn. Actually, if you see clearly, the doctors and the psychiatrists, all the doctors present here, it looks more like a neuron, if you see. So it's a rough diagram of a neuron. So probably, yes, that's the integral part of our brain. And ultimately, that's what we are all talking about. So dementia is the most challenging and the most difficult, I think, subject to talk about. And for a neurologist, it is also very, very challenging on a daily life to see patients, not only from the elderly, also from our own age group, because in the advent of technology, media and everything, we are slowly using our brains less. So that is also causing an early memory loss and a lot of issues with the youngsters, as well as, of course, proceeding to the elders. So, the application, I'm very much excited to use it because it's one of a kind, and we need definitely an assistance to bridge the gap where we lack. After the diagnosis, we kind of come to a conclusion whether it's an Alzheimer's, whether it's a vascular dementia, whether there's a reversibility angle to it, or whether there is no irreversibility. So after that, we have a few drugs in the pipeline now. There are new drugs for Alzheimer's also, but how much ever we do, or probably we can just slow it down.
It's tough following up after all the clinicians have talked. But I think this is a pivotal moment in the adoption of AI in healthcare. 90% of AI in healthcare surrounds automation or augmentation of diagnostics or therapeutics, right? So it really wants to address the problem, hey, how can I replace my specialist, or how can I make my specialist better? But 80% of healthcare actually happens outside the specialist's office, right? The caregivers, be them certified caregivers or family caregivers, they take up probably more than 60% of the medical GDP, like the amount of time and effort spent in caregiving. So I think if AI starts addressing that, I think it's the right direction to move, right? And there's really three things today in tech which is helping solve the problem, right? The first one is what we call empathetic AI. As we all know, we have all used ChatGPT at some point, or even Gemini. Now Google results come automatically with AI, right? The biggest flaw in AI is that the biggest benefit is that it's non-judgmental, but the biggest flaw also is that it cannot judge based on context. So it gives very non-judgmental answers, which is great for specialists, but it is giving you an answer without any personalization or context, right? And especially with memory care patients who have repetitive conversations, AI can get
So again, it's a surprise for me also, and I'm not a public speaker clearly. So I'm here as I'm Dr. Nephrologist, consultant nephrologist in Dr.
And Grace and Alpi did very good work at bringing up that image. But when it comes to dementia and my understanding of dementia, right? So I think of it as the entire knitted fabric of life coming undone slowly, and it exposes a lot of elements of patience, and it actually takes a dig at their dignity. So that is how I see dementia, and there is a small fraction of patients whom we can actually help with surgery, like normal pressure hydrocephalus is one of those things which we can identify, and that is why I'm here. And the other thing is, I see this entire project as a very ambitious project. I see that they've touched every element of dementia care, right from the clinical assessment, the evaluation of patients, grading them into mild, moderate, severe, and exactly tailoring the care based on that grading. They've also taken into account the vernacular which the patient understands, bringing in the human element of compassion and towards the patients by bringing up this life book that's put together. And also from the administrative perspective, they've thought about how patients can be convinced into getting into the entire setup of dementia care and care homes. And I think they've done a fantastic job of thinking about fall prevention, about patients spending a lot of time in the bathroom, being sensitive to that, alarming. I think they've taken a whole bunch of things. It's not an easy task to put all of this together and trying to make one platform that gives you everything. I think from what I've grasped from what they're saying, I think they've thought of every minute detail and they're trying to work on every part. I'm sure this is not it's not the end product. It's going to be an evolving product, and I think that is where clinicians like us would like to and also love to be part of your team to tell you, give you inputs of what else you could do. And I'm really happy that Shalu invited me over. She's my kindergarten classmate. And it's nice that I'm sharing the stage with all these esteemed people around here. So thank you.
So next up, we want to have a small fireside chat kind of a conversation, very casual. I just thought we can use this opportunity where I have all of you experts here and just speak about. I have few questions and we could just take those take those topics up and discuss and speak about what is missing and what we are building and what we really need to build going forward in Remina and dementia care. I'd request Shrikar also to please take a spot on the stage. Okay, so I just have a few questions and I'm thinking it will be a good, the first one. No, I've not leaked any question paper. Yeah, so so no right or wrong answers. I mean, it's not, it's more about, it's more
I think that number them accepting help, asking for help, and finding solutions, and the stigma. I think the stigma it's still there. I think in our society to seek for help and to say that your father has dementia, sometimes it's still looked on. So these are things that we try to address. So if you would ask me to rate it, I think it's the
find that persons with dementia can have a good quality of life. They have help. So they just take it as if someone has got dementia and that's it. They can't lead, they can't have a good quality of life. But they don't know that there is help which is available, and definitely they need hand holding. But many of us are there, and another thing is that trust. So we need to spend a lot of time with them so that they will trust us. So good quality of care and good.
So that's something which many people go through. I think that is an inherent lack of awareness which we talked about, and also how we think, and this is common even in chronic conditions like hypertension or diabetes management, and even chronic disease, kidney diseases management. I'm sure you will come across where people discontinue medication in general, and how we look at any condition as a interval. So that's a model I think we need to think about and change.
So, second thing, medication. So, chronic conditions, neurodegeneration, the process itself, again, degeneration. Matra kudutha piragu, their instinct is better agano. If it's not getting better, they're like, matra kudutha mosam aidichu. So, this is something that we see in OPD. And so, these are the main things. So, they think that their family members are acting. The third thing is, vayasana idella varum thane. Idella vayasana ellarkum pesama irukka vendidane. Which means they're okay if the person, their family member, has memory disturbances as long as behavioral disturbances don't develop. They are okay with that. So, how do we get them to understand this part? The nature of progression of this illness. How do we sustain that knowledge in them?
Like sir mentioned, normal pressure hydrocephalus. So we do a shunt and we reduce the pressure. So to some extent, yes, they do get reversed. And when it comes to post-stroke, post-traumatic brain injury related dementia, of course, it depends on the area where the brain got affected. And yes, to some extent, yes, we can get back to the original. Not to the full extent, but some amount of functionality will always be there. So that will be the first question of the caregiver, whether I can manage with my father or mother or grandfather, whoever it is at home. So So once they get to know that it is not going to reverse or it's going to progress, that's where the actual the fear starts, because the caregiver maybe like he belongs to the group where he's actually working hard for his family, he has to earn and he has to travel places, he has his own ambitions, he has his own dreams. So now he has to take care of his or her relative, and that causes a series of events in his probably life where he has to manage and actually put his leg in two worlds. One where you have to, that's your responsibility or duty towards your parents or your grandparents, relatives, and the other is your own life. So that's where the divide happens between the in the caregiver's mind. It's not about whether they want to do it or not. That's the first thing which actually strikes in their mind, and I think that is where we have to more than the patient, I think we have to educate the caregiver, support the caregiver, and he needs more probably love and understanding from the society as well as his own people, that he's also struggling. He is also having, he has to undergo a few of the sacrifices which probably he has never dreamt of. So that thing has to be, I think, clearly made it clear, completely clear to the person who is taking care. Yeah.
Well, we'll change the questions. I have a question to all doctors.
To be honest, both neurology and psychiatry, at the training level, we don't get exposure to dementia much. Okay. And there are experts, cognitive neurologists who deal exclusively with people with dementia, and there are psychiatrists who are exclusively dealing with people with dementia. And I think it's important that, and there are also geriatricians who deal with people with dementia. It doesn't matter which specialist you go to, as long as you go to someone who has the experience, but please go to someone. I think that's the first point. I think it's important that you go to someone. And to your second, I don't know, are you meaning by NPI, neuropsychiatric inventory?
No, the non-pharmacological intervention.
Okay, fine, thank you. Okay. Yeah, non-pharmacological interventions are important, and I think antipsychotic dose reduction is important, but that comes secondary to when you start having diagnosis happening in the first place. The important reason why people prescribe antipsychotics here in India is the fact that there is no support system to manage or to deliver non-pharmacological interventions to persons living with dementia. So you have someone who is not sleeping at night, someone who is very agitated and restless and trying to leave the house, and you have a family member, as Madam was saying, you have a caregiver who has to manage their own work, and if the person is not sleeping well at night, then their whole daytime schedule is up in the air. So it means that then the person has to be given medication to reduce their agitation and help them sleep better, which means
indicators of whether the elder is doing well or not is only associated with the behavioral symptoms. The elders, like memory is declining, but they're calm, they're quiet, they're not troubling anybody else in the family, they're okay. But only when the agitation starts is when they feel like, okay, we have to figure this out. But for agitation is not directly connected only to the behavior symptoms. There's a lot of lack of routine, social isolation, non-participation that happens, that little by little it drives the agitation because they're not kept active during the day, sleep gets disturbed, appetite gets disturbed. If fatigue hits, then disorientation hits. It's like an entire chain reaction. So it's at least most of the work that we do, we usually advocate a combination. It's never one over the other. It's like you start somewhere, but you also at some point have to get into knowing medication can help to some extent, routines can help to some extent, stimulation can help to some extent, talking to people helps. So it's important that we're able to build that entire system for them. It's currently something that we're looking to fix as with the community involvement as well, but it's still in progress over here as well.
You cannot really apply for the question that you asked. You can't exactly apply what happens in the US to the Indian scenario because the social structure and fabric is very different. So sometimes, for instance, patients with a dementia, if they're like diagnosed and they seem to be a better fit in a nursing home or a mental care facility or dementia care facility for that matter. Even if you try to insist that they need that kind of a facility here, patients take it upon themselves to take care for these patients. So what really happens is that the family would miss out on picking up vital, turnarounds, like seeing that they're actually deteriorating, over, sending them over to a care facility. So that's what happens most of it. So, and they also work on half-baked, half-knowledge. A lot of the family members go back to Google or whatever, and they think that they know what they're dealing with, but they really don't know. So for you to have a one-on-one assistance with the family is something that you should see also. As a product, if you're trying to do that, to educate the family is also very important. And to identify caregiver burnout is very important. So that is something that impressed me about your product. Because they would go on doing, like I know a lady who gave up a really good job, came back from wherever she was and stayed with her parents for almost 6-7 years until they finally passed off. And her life in the meantime is lost. And then for her to revert back to where she was is not going to happen at all. So all those things need to be, the patient's caregiver has to be sensitized to these kind of things, and they should be made to feel that it's okay to put them in a care facility because they're going to get better care than what she can give at home. So I think those are the elements those are the human elements that you need to work on.
So even whether it's cognitive stimulation therapy or getting them on a routine, or just getting into a routine of saying you wake up in the morning, look at the calendar, look at the time, and then start building the routine. So a lot of the caregivers initially, that cause there's gender differences here also, but there's a lot of hesitation and there's a lot of need for reassurance from a professional, either the doctors or the caretaker they're working with, to know that they're doing it well. So that is, if done right and they reach out and we're able to reach out to them, the participation is much better.
That is, the elders need that reassurance from?
No, the caregivers need the
caregivers
reassurance.
themselves. Okay.
Yeah. So whether it's the medication, so let's say the medication is for both the behavioral aspects as well as the memory aspects, and they're suddenly noticing a change. The elders sleeping a little bit more. There's an immediate panic. Oh, is this too much? Is this too less? And then unfortunately we have enough family members around or friends around to give us their opinion of what they think is happening. So there's a lot of hesitation initially that the reassurance from a professional
have to tell the caregiver or the person who's taking the initiative to give the targets. Okay, these are some things which you have to notice, these are some things which you have to monitor. So, as ma'am correctly said, they give it for 2 to 3 days and then they suddenly get panicked. Okay, oh my god, they're not getting up, they are just behaving very odd. So that's not the place where you have to get panicked. Rather, you have to come back to the doctor, tell them that, ma'am, this is what happened.
When I meet our elders at the daycare, the immediate thought that comes into my mind is, are we actually doing the right thing, and are we doing enough? And I think that's quite an open-ended question as well, because I know that there's a lot to do, and the dementia and the situation it is in our country and in our society, I think there's a long way to go. So Anala, it's a big challenge for us, and that it keeps us going, but that's the thing that gives us sleepless nights.
One more question to all doctors, right? So I'm 50 years old, I manage a 50-member team. At times I forget my team member's name. Is that dementia? How do I figure out, when do I need to realize that I take my mom or my dad to a doctor? It is not normal. How do I?
Sometimes it might be intentional and it happens to my husband quite a lot.
Today morning we had so many items to eat. So suddenly I said that, okay, I had this item which is from the North India, it is fried in this oil, but I'm not able to recall. Something you have been eating daily, you know it's puri, but you're not able to make, you're not able to name it. So there, you're lost there. So you're basically finding a word for it. So if it starts happening very frequently, and this we can see in all our OPs, they will know the function of it. It's suddenly the most common words.
Remina is not to diagnose or not to even treat dementia. We want to make sure we keep our strengths with us. We are only technology people. We are good at writing computer programs, and that's what we are doing in Remina. And primarily, why now Remina is a great question, because earlier, at least 3-4 years back, like Santosh was telling, there was no multi-model LLMs available, right? So I cannot create a live. I can still create, but I think I need to, do a lot of, or I need to create an LLM on my own. But now with things like ChatGPT and Gemini, it becomes so easy for us to create a, LLM, to create a live book digitally, and then generate different kinds of questions that can create routines for themselves, which is one of the biggest, burden for Purnima ma'am is creating those activities. Now with Remina, you just tap on a button, depending on the live book and depending on the activities, what you want to run on your memory care center, all those are getting created automatically, and then those get assigned to the event residents. For your group activities, it also makes a mix and match, whether person A goes well with person B in terms of dementia condition. Can they be part of this group activity or not? So that triggered, the technology advancement triggered me to build something like this.
Thank you. So now that you mentioned life book, so question to clinicians, how important is having a life book to the caregivers? So yes, family members, they know that person, they know their personality, what they like, memories, they share memories as well. So it could be a little easier to connect with that person as such, right? But when they come into care facilities like yours, now there, how important is a life book, the role of a life book for the caregiver at your facility to be able to take care of the elders, right? And how important will that be?